Hello, and welcome to another podcast from the American Society of Nephrology. Today, we are being joined by Dr. Kenar Jhaveri, the Associate Chief of Nephrology at Northwell Health. Why don't you just tell us a little bit about what the healthcare system is that you guys run, and just give us a little bit of the scope of what you've been dealing with?
Yes, no. Northwell Health is a composite of around 23 hospitals in the New York City, Long Island, Westchester area of New York State, and the two big tertiary hospitals are North Shore University Hospital in Manhasset, New York, and Long Island Jewish Medical Center, a mile away from there. Basically, these are the two largest health system hospitals, tertiary centers that most of the nephrology division that I'm part of function and take care of patients. So we have a large division of 23 nephrologists that take care of patients in these two hospitals with a 8 fellows fellowship program. So we were right in the midst of this epicenter, this epidemic here in New York, and we were able to see tons of patients that came in through both these hospitals and also had a lot of acute kidney injury associated with these patients. So that's how nephrology got very involved, as you probably heard from other centers.
Certainly. Tell us about what time, give us a time frame of when things really started to ramp up for you guys.
Yeah, actually, it all started probably early March or so. And I still remember I was on call that one weekend. And I remember going to the hospital just a month before and would see a case of amyloidosis or cardiorenal syndrome or some strange cancer drug causing kidney injury or heart transplant with kidney injury. And all of a sudden, it was turning into COVID, and kidney injury. And what just happened here? It just basically the whole thing had turned around into a COVID hospital. And it happened within a span of like 2 weeks without us even realizing how fast this was happening. And I've never seen this happen in the 10 years I've worked here, where a place was just turned upside down to make things work within like a short period of time. So I would say around early March is when we started noticing some of these things.
So I imagine that it's been pretty intense ever since then.
I mean, intense is probably an understatement. I couldn't even recognize the people. I would walk into the hospital, all those makeups and gels that people used to have were gone by and replaced by N95s and surgical masks. All these nice suits and dresses were all replaced by scrubs and surgical gowns. All the ICUs were turned into just medical ICU beds. There were ICUs popping up at places where we didn't even think there would be ICUs. Even our auditorium, which used to have conferences, was turned into a hospital bed. That was the environment we entered as nephrologists. And then we had to deal with our arena of seeing kidney disease within that whole system.
Well, tell us a little bit about that, what you experienced and what you saw. We're going to get to your study in just a little bit, but just give us a feel for what it was like as a nephrologist on the front line.
Yeah, so we kind of anticipated an increased surge in nephrology consult. I'm glad we did, so we were very well prepared. Probably like mid-February to end of February, we were watching what was happening in China and Italy, and we, in anticipation, had prepared ourselves to be in the hospital more than the outpatient, so to de-stress what could have happened. But compared to, say, getting 5 or 6 consults a day on average, we were getting 15 consults a day, and all of them COVID-related consults. So we had almost like a 30 to 40% increase in number of consultations of kidney injury. They were very severe kidney injury requiring like dialysis the very next day. So this was not like one of your consults that you would get and not have to worry too much about the patient. But this was like really, really sick patients getting into kidney injury. And I would say we had anticipated that it would be around 20% or 25% of patients we were getting called for kidney injury. But that was what got us into looking at the numbers specifically.
Okay. And it turned out to be much higher, didn't it?
Correct. Yeah. So when we studied it systematically in a recent publication, we found it to be 37% at all kidney injury for all hospitalized patients in the 13 hospitals we studied in our health system. So that's around 36.6% was the exact number.
Well, just tell us real quickly what exactly, what were the parameters of the study that you did, and where it has been published.
Yeah, so this study looked at acute kidney injury rate and timing and outcomes of hospitalized patients with COVID in 13 academic centers in our health system. It was published in Kidney International. It was around 5,000 or a little bit more than that patients admitted. AKI developed probably 37%, 36.6 exactly, so 1993 patients. And more importantly, stage 3 acute kidney injury was in 31.1%. And of those, 14.3% required dialysis. So that's a pretty big number. So out of all the patients in the hospital, 5.2% required renal replacement therapy. And what was even more surprising was the patients who were on respiratory failure on mechanical ventilation. They actually developed AKI much more than the ones who were not ventilated. So I would say around 90% of them.
When I was going through your study, and I got to that, you guys quantified it at 89.7% of those on the ventilators, and I was just stunned by that number. I imagine you guys were too.
Yes, we were stunned, but not completely surprised. What was more interesting was the timing of AKI was around peri-intubation. So the most of the AKI that happened also happened around the time of intubation, and that's we show that in a nice figure. And this is, I think, it's nothing to do I don't think it's anything to do with the virus itself. I think it's just how sick these patients are getting around the time of them getting intubated, because they get this cytokine storm that's happening, and the sickness, the blood pressure drop, the toxic, interleukins that are being produced, and all of this is probably affecting the kidney because kidney gets a lot of that blood flow. So it might not be direct virus effect. It probably is just how sick and toxic these patients are getting when they are getting to the ICU.
You did use the term, I think, in your study that it clustered around the time of intubation. Okay,
correct.
So that and it was very, very tightly clustered. It seemed to me as a layperson.
No, that was very surprising to us. And, we wanted to really understand that a little bit better. And that's why we kind of looked into those, vented versus non-vented patients to see what was the difference there. So those were the real big findings. We didn't, some of these patients at the time of our study are still in the hospital, I would say around 39%. So, it's hard to really comment on the total outcome of these patients, but of the ones that we looked at, 35% of them actually died. So if you had AKI, 35% did die, 26 were discharged, 26%, but there's still 40% of them in the hospital still.
And I know I'm going to ask you to make a prediction that you can't make, so I'll just go ahead and put a caveat out there.
Yeah.
I've talked to many nephrologists in the last couple of months who have expressed their concern that they don't have a real good feel for how many of these AKI patients will ever regain renal function, and end up being ESRD patients. Do you have any thoughts about that?
So we, of the patients that got AKI in ours, this initial study, we did get some patients who got discharged, and the terminal creatinine on discharge was 1.7 or so. So there are people who are getting this mild stage 1 and stage 2 kidney injury and are getting better and going home. But, we still don't have the full outcome story. I think we have to wait for 30, 40-day outcomes to really, see what the true outcomes of these patients are going to be.
We do a lot of discussion about policy in these podcasts, and this one is not so much about policy, but we have been having this conversation with the Centers for Medicare and Medicaid Services and basically signaling to them that probably in June and July and maybe August, there may be some significant reclassification of patients, and
Yes.
they may see real change.
Yes. Well, the only caveat to some of the ones who are on dialysis, they do have a high, we did have patients who uh, had a good, I couldn't get an exact number to you, but I would say around 90% of the patients that were requiring dialysis actually did not make it.
Yeah.
So because it's happening so fast and acute, but again, that's preliminary data because remember we have to still. This is only a 2-week outcome. We want to wait and see what the remaining 40% that were still hospitalized. How did they do to see the true number?
But you did go, if I'm not mistaken, you did evaluate the records from March 1st to
Correct.
April 5th. Okay.
Correct.
Yeah.
Yes.
So more like 5. Okay. I was also, being in the category of a male a little bit upper in his years, I was looking at the numbers, the predictors that you were indicating, and it did seem to really have to do with a lot with males, a lot with hypertension and diabetes and body mass index. Am I reading that correctly or not?
So actually, when we corrected for all the factors, when there's two types of analysis, one, when you do in a study, one of them is incorrected and another is corrected. The corrected analysis did not put males. Actually, it was older age, diabetes, heart disease, black race, hypertension, need for ventilation, and medications to keep your blood pressure up, called vasopressors medications. Those were the indicators of risk for acute kidney injury. So, maybe in COVID, there might be a risk factor for men, and people are noticing men and high BMIs. So we did not find the BMI or men to be a risk factor.
But you did find race.
Yes.
To be so.
The African American race, was a risk factor.
That seems to be becoming a bigger and bigger piece of this story, and the pandemic, is that it does, at least in the United States, it has hit the African American community very, very hard.
Yes, and especially in the kidney disease world, we already knew this, right? They do have a high preponderance of getting kidney disease, so we were not surprised that that was a risk factor for kidney disease with COVID as well.
And am I correct that you primarily studied hemodialysis, intermittent hemodialysis, and renal replacement therapy? Is that correct?
Yeah, so this is hospitalized patients who did not have any kidney disease before going in, and we kind of made sure about that. So we studied the need for dialysis in the hospital, and both actually. We looked at how many of them required hemodialysis, how many of them were on the continuous form of dialysis, and how many of them required a combination of both, because when you get transferred to the ICU, sometimes the type of modality of dialysis does switch to the continuous form. It didn't really matter, but it's important for a nephrologist to know how many of them required the type of dialysis that we used. But it also depends on center to center. Some centers don't have a continuous form of dialysis modality, so they're only left with the regular intermittent hemodialysis modality to treat even the sick patients.
Part of the reason why I asked is I was curious if there had been urgent start PD involved.
Mm-hmm. So we, as a division, decided to not go with that concept, only because we had learned from our pulmonary and critical care colleagues that proning the patients, which is putting them on their abdomen, even if they're on the non-ICU floors and ICU, was actually helping their pulmonary status and the COVID. So if we started doing PD, it would actually be complicated because they were not in the right position to do good PD. And second, we had planned way early and ordered enough supplies and machines to make sure we were covered for a very high rate of kidney injury. While we had some glitches, we actually end of February had planned and bought and initiated a protocol to not have any problems in terms of supplies and demand, in terms of dialysis equipment, fluids, filters, personnel, nursing staff, and the nephrologist. I think it's important because if this has the second wave comes, and there is another place in the U.S. or the world that has a big impact like New York did, it's very key to plan early and not wait till the surge happens. And I'm so glad our leadership decided to do that way in February and spend the extra money and extra time in meetings to get that planning ahead. And we also used other modalities like a SLED and borrowed ideas from Vanderbilt University and their ideas of doing certain type of nursing to SLED ratio, and that really helped. Putting all the nephrologists in the hospital and have only a minimum amount of them in the office also helped with the volume and the stress that our fellows and attendings might have to go through. So really de-stressing them and not letting them carry more than 15 patients, that helped. And giving a lot of time to the medical directors of dialysis units and giving them protection and extra help so that they can deal with the outpatient surge of these dialysis patients getting COVID. That is also very important. So I think a lot of planning has to go into effect. And since we had that in place, we didn't really have to get into the PD part.
Well, I was going to ask you about recommendations you have for others and for listeners in particular about planning for a possible wave in the fall and so forth. And actually, I think you just gave a very good outline of what you guys did and what you think worked.
Yeah. I mean, two additional things I would say is have a point person in nephrology who is your sort of like the keeper for all the supplies, all the nursing staff deployment, and sort of your machines. And that person would actually do a call every day to us and make sure that we are up to date, or a text that this is the supply issue right now, this is what we're dealing with. It really, really helps. And another person to kind of be the point person to make sure your televisits are going okay and they're orchestrating those well. And the third person for the dialysis component of your division. I think delegating the work and giving people power to do things really also inspired a lot of people and gave them that drive that, they're not just sitting in the back seat here, but we are the frontliners here, nephrologists, and are able to, fight this and help our patients.
So I was going to ask you, from that list of things that you were recommending to do you have a top 3 to 5 recommendations that you really would say are the most critical for institutions to think about, systems to think about, nephrologists to think about?
Yes. So I think the first is early planning, not waiting till the surge happens. 2 is, getting your fluids and supplies and getting the right people from your institution involved early to get the supplies, and even if it's available as a backup, you don't need it, be there. Third is having key personnel kind of in charge of certain things, and reporting to you on a daily basis. And 4 is just, instead of other parts of medicine that were being redeployed into being in the hospital, like cardiologist was going to go do ICU rounds, and rheumatologists were putting dialysis, were being hospitalists. As nephrologists, just redeploying within your own practice is just being in the hospital, and giving your other nephrologists a little bit more space and time to not burn out was probably more important of all the things.
You had something in your study that caught my eye. You described your urinary results as provocative.
Yeah.
You used that word, provocative. I wanted you to tell us what you meant by that.
Yeah, so the nephrologist will quickly understand this. So the type of kidney injury we see with shock state or these type of ICU related kidney injuries, usually something we call acute tubular necrosis or acute tubular injury, or ATN. And that's usually not a disease we see with protein loss in the urine or blood in the urine. It's usually not seen with that. So the degree of protein in urine findings we saw was disproportionate to our pathology we were thinking that was going on in these patients. That's why it was provocative, because not many biopsies are being done, or and there's not much description about what exactly is happening in the kidney. I can say that we have unpublished data of the biopsy. We did do a few biopsies on our patients in the ICU, and it is to the nephrologist out there, it is tubular injury. That's the most common. We found mostly tubular injury. We did find some rare stuff like thrombotic microangiopathy. We found, the already published entities like collapsing glomerulopathy, which is a glomerular disease, which is why we might see some protein in the leakage. But that's rare. I think the most common thing we still see is this tubular injury, and I can't explain why there is so much protein loss. With that, it's possible because it's happening so rapidly, and this whole ACE2 effect might be leading to a tubular loss of protein in a significant amount. It's just my postulation, but without further, scientific studies, we can't really, besides thinking about it and, just making suggestions, nothing else we can say.
We have been, and when I say we, I mean the committees of the American Society of Nephrology that are really dedicated to making requests to Congress and requests to CMS. They have been very focused on the need for additional funding to NIDDK specifically for COVID-related issues with the kidney. And we are hoping to get some success with that as we move forward this summer and keep our fingers crossed. I would imagine that was something you would find to be a very useful exercise.
Oh, yes, I think it's very important because it might be helpful not just for COVID-related kidney disease, but any sort of viral-associated kidney disease. We might learn so much from everyone's work out there, and NIH supporting that and the organization supporting this type of research will be not just helpful for COVID-related kidney disease, but in general, we will learn so much about tubular damage and other virus-associated kidney diseases.
Well, this has been a fascinating conversation. I'd like to invite you to kind of share any comments you have as we wrap it up here that you would like for the listeners to think about or to be aware of.
Well, I just, while we were going through all this, everyone was scared. At the same time, everyone had a sense of pride because we were all together in this battle against COVID. But there was one of our colleagues and my good friend, Richard Barnett. He had this quote, and I think it just resonates. If you don't mind, I'll say it. This is literally a battle zone which we're dealing with. Quite honestly, for the most part, it's exhilarating. You're living history, he said. Nothing has prepared us for this. Soak it. Hopefully, 40 years from now, you will tell your grandkids how you served on the front lines of the great 2020 pandemic. And you may never again have this opportunity to be involved in something more meaningful again.
We really appreciate you joining us. This has been a fascinating conversation, and we want to keep following your work and see what else comes out of this discussion. And we just can't tell you how much we appreciate your being here today.
No, thank you, and thank you, ASN, for their time.
This podcast is copyrighted by the American Society of Nephrology, all rights reserved. All content in this podcast is for informational purposes only and is not intended to be medical advice. This podcast should not be used in a medical emergency or for the diagnosis or treatment of any medical condition. Please consult your doctor or other qualified healthcare provider if you have any questions about any medical condition or before taking any drug, changing your diet, or commencing or discontinuing any course of treatment. Thank you for listening to this podcast from the American Society of Nephrology.